Room 418, bed 1, initials MJ, is a 64-year-old female. She was admitted for rule-out sepsis in the bilateral joints of her knees. She was admitted on 9/26. She has a history of diabetes, hypertension, congestive heart failure, and anxiety. She last received her antibiotics on 9/26 in the morning, and they DC'd them 9/26 as well. She has an allergy to penicillin. Her current vital signs are temperature 37.7 degrees Celsius, heart rate 74 beats per minute, respiratory rate 18, O2 sat 94%, blood pressure reading 122/43. She is on room air. Her lung sounds are clear and equal. She has no history of fevers in the last week. Her skin is intact. She does have a stage 1 pressure ulcer on her coccyx. She has a 20 gauge in the left hand for her IV site that is saline locked. She does not have a Foley, and her last bowel movement was 9/25. So her goals for today were up to the bedside commode for voiding and bowel movements. She is pending discharge upon assessment of walker utilization. So the goals for her today are to use the walker and, again, up to the bathroom bedside commode as much as possible, or to the bathroom. And then patient education is how to use her walker properly and safely. And then the possible orders for today are discharge as long as it's safe for her to go home. And then, so based on patient conditions, what do you expect today? As long as it is safe for her to go home using a walker, I expect her to go home. If I could do anything differently, I would study even more than I already have on the head-to-toe assessment and doing it on live people instead of just reading it, because I felt very nervous to do it on an actual patient for the very first time. And I felt like I jumbled around, and as much as I felt prepared before I went in, the minute I got in there, I went blank. One thing I like today, I like doing our skills on actual people rather than makeshifting a way to do them. I learned how to communicate doing a head-to-toe assessment with a patient. I am an extern at General, but I don't do head-to-toe assessments. I don't talk them through what I'm doing other than I'm going to take your vitals, and usually it's I'm going to take your blood pressure, not vitals, because when you say vitals, they get a little nervous and concerned. So if you say, I'm going to take your blood pressure, they generally understand exactly what you want. One thing I didn't like was the floor felt very understaffed and all the nurses were very busy. So I didn't see my nurse very much, but that's healthcare and the situation we're in. Every floor is understaffed. Every floor is dependent heavily on travel nurses or the clinical resource department at this point in time because of the global pandemic going on. So it's just one of those things you take and you go. How was it working with a nurse? My nurse was wonderful. She was very helpful. She told me anything I needed to know about the patient. She told me about some of her other patients just because they had a little bit more going on than mine. So she was very helpful and very wonderful. She was just very busy. And it was understandable. How do I feel my communication was with my patient? I feel it could have been better. For the first time being in the hospital as a nursing student and the first time doing a head-to-toe assessment on a live patient, I felt it was okay, but there's always room for improvement. There's always room to get better and more comfortable talking with patients. there's always room to get better at explaining what you're doing to patients, and I feel that over time, and the more I do it, the better I will get.